Thank you, Ryan, and thank you, Maria, for organizing, and also thank you, Lynn, she's probably outside, for organizing this venue and session. Today, I'm going to talk about retinitis pigmentosa and to go through the historical background, maybe why we shouldn't be calling it retinitis pigmentosa, and then some of the research that we're doing at the Lions. It was around 1857 when retinitis pigmentosa was named. It was named by a guy called Frans Donders. The Frans Donders is Dutch, and he's got 8 older sisters. Thankfully, the parents persisted because without Donders, we would be left in the dark for quite a while. He discovered myopia, long-sightedness, astigmatism. So he was sort of the first person to understand spectacle corrections required for these problems. He was also instrumental in understanding cognition. So there's actually a Donders Institute in the Netherlands dedicated to the study of thinking processes and mind and cognition behavior. So he named this condition called retinitis pigmentosa in 1857. After several other mentions of this condition, so 1744 is when night blindness, familial night blindness, was first discovered. So that's back in the 18th century. And then through the early 19th century, people recognized that there were pigments in the retina associated with this night blindness. And 1853 is when somebody looked into the eye and found these pigments in a patient with night blindness, and Donders put it all together to call it retinitis pigmentosa. So retinitis actually means inflammation of the retina. So there was thought that this is an inflammatory condition. And pigmentosa is just pigment, black bone spicules that we see. I'm going to go through some of the features and highlight that not all RPs are RPs, and not all RPs look like RP. So this is the problem we have. So the most common feature of RP is, well, it's really defined by the loss of rod photoreceptor cells, followed by cone photoreceptor cells. So we've got about 120 million rods in each eye and about 6 or 7 million cones. We don't know how many rods we have to lose before we start losing cones. And we do know that cone survival depends on rods, strangely. And there is a factor that's called rod-derived cone survival factor that groups in France and other places have been looking at to see how we can keep the cone cells alive even though there's no rods around. So that's the basis of retinitis pigmentosa. And there are other features such as night vision impairment, loss of peripheral vision. But the classical features in the eye are 3 things. One is the optic nerve looks a bit pale because of scarring in the optic nerve. There are pigment spicules in the retina because this cell called RPE migrates through the retina to form these bone spicules. And finally, the blood vessels are thinner. So these are the 3 features. And then I'll come back to these because these are features that are not always present. And this is where people get confused. This RP condition was thought to be one condition, but obviously we know it's not one condition now. But it was distinct from other conditions such as Leber congenital amaurosis, or LCA, when people were born in the first few months of life manifesting with wobbly eyes and blindness, very severe blindness, so that's called LCA. So we tend to separate RP from LCA based on the onset. And then there are other conditions that predominantly affect the cone cells rather than the rod cells. So these are cone rod dystrophy or cone dystrophy. So that's another group that we try to separate from RP. And then there are conditions that affect just the macula, called macular dystrophy or pattern dystrophy, that just affect the central part of the vision. And that's clearly very different from RP. And finally, there are conditions that occurs very early on and stays stationary throughout the entire life of the patient. So for example, things like achromatopsia and congenital station night blindness are stable conditions. So these people never lose their vision. So what they have at birth or shortly after birth, as they develop their vision, they'll keep that for the rest of their life. So all these are distinct groups of inherited retinal diseases that we should be aware of. Now, shortly after the description of RP, people realized that there are actually different types. It's not just one disease. First of all, the inheritance is different. So we know that there are dominant RP, there are recessive RP, there are extant RP. And in fact, the majority of RP is simplex. So what it means is that we actually don't know what the inheritance is because there's only one person that has it in the whole family. And that makes up almost 30–40% of the people we see. There's no other family members with it. We can't assume it's dominant because oftentimes we don't get to see their parents, or their parents have no symptoms. We generally will know if they're X-linked because, if the mothers are carriers, we can see them, but if they're not around, then we can't see them. So if only one child has it, we don't know. And out of all these, what we call sporadic or simplex, the majority are recessive, and some are dominant, and some are X-linked. So I'll come back to this concept. So what dominant means is that you need one of the two copies of the gene to be mutated to manifest the disease. So we all inherit one copy from the mom, one copy from the dad. The DNA sequence is littered with variations. Some of these variations are damaging to the gene and they're called mutations. So if we have one mutation in the gene and causing disease, that's called dominant disease. In some other genes, we need two mutations in the gene, so one from the mom, one from the dad, to be together to manifest a disease, and that's called recessive. X-linked disease is different because it involves the X chromosome. Males have X and Y, females have X and X. In a male with an X-linked disease, they manifest the condition because they only got one X chromosome, they don't have a backup normal gene. Whereas in a female, they may or may not manifest the disease depending on which X chromosome is inactivated. So every cell in the body in the female has two X chromosomes. Not both of those are working at the same time. So the body decides which one to shut down. So only one X is working. Now, if the cell in the eye decides to shut down the X chromosome that has no mutation, then the one with the mutation will manifest and cause disease, and vice versa. So that's why the X-linked carrier is a bit tricky, because some female carriers will have severe disease and others won't. So that's an inheritance pattern. So we already know that the RP disease is not one, there's different types because of the inheritance. We also know that the symptom onset is different. There are people with RP who manifest very early on. They'll say that they had night blindness ever since they know. Ever since they were toddlers, they couldn't see well in the dark. And it's not until they're 15 or 16 or started driving, they realized they couldn't see on the side. So they drive for a few years and decided that's a bit risky. So they give up driving. And so there are people who manifest or who present later in life, not because of night blindness, but because of the visual field loss. I also see the other spectrum of people with RP who comes in and see me in their 60s or 70s, carry on the whole entire life normally, driven around completing as though nothing has been wrong, hardly any night blindness, but they have features in the retina that suggest they have retinitis pigmentosa. And then the X-linked carriers, females, could be extremes as well. They could live their entire life not having any issues with their night vision, or could manifest peripheral vision loss, just like a typical RP quite early in life. So the symptom onset is different. The severity of the night vision deficit is different. The amount of peripheral vision loss can be quite different as well. And then this ideas of pigmentosa is worth mentioning, because there are many situations where we see an RP patient without pigment, and so they'll present with symptoms that suggest there may be some peripheral vision deficit, but when a clinician looks into the eye, they don't see the pigment, so they don't think about retinitis pigmentosa. And so diagnosis can be delayed until they have what we call electrophysiology done, which shows a typical feature. There are also RP cases where there are white dots instead of pigments, or a combination of black dots and white dots. And the distribution is different. Typically, we see these black dots all scattered around the entire retina, particularly where the rod cells are most concentrated, and that is just beyond the back part of the retina. So the posterior pole makes up about 50–60 degrees across, and just outside that, there's these black pigments. There are RP where it's only the bottom half that's affected, or just around the center that's affected, nothing else outside, nothing else inside. So what we call pericentral. And the sector RP is just the bottom half, and people think that's probably related to the sun shining in and affecting the bottom part of the retina more severely. And there are also distributions where it's just one side and not the other side. Now we think that this kind of RP is probably not genetic, it's probably inflammatory related. There are other additional features that are not encompassed in the classical triad, so the optic nerve paleness, the blood vessel thinning, or the pigments. So there are other features, and this is what makes the diagnosis rather difficult, and some people take years to get a diagnosis. Firstly, some people may have just wobbly eyes or deviated eyes because of uncorrected focus, so especially in kids. So they present to kids' eye specialists with eye that's slightly deviated. So they wear glasses to correct that, not realizing actually there's underlying problem in the retina, because at that stage, they probably don't have any symptoms of visual field constriction or pigments in the retina to see. I've come across where kids been treated for myopia or short-sightedness and not realized they had RP. So a lot of RP is associated with short-sightedness. And so they've been put on eye drops for treatments of short-sightedness for a few years. And then suddenly somebody asks, oh, can you see at night? Or is there issues looking around side, they'll be clumsy. So then the idea of RP came through. Some kids have long-sightedness, so they are put on glasses and still can't see well. And then eventually somebody looked at the retina or did a scan and found, the structure's a bit different. Maybe there is something wrong with the retina. Cataract is very common. There are people who've been referred for cataract surgery by optometrists, are not realizing there's something wrong with the retina, so cataract surgery is done, and then suddenly it's realized that, okay, vision hasn't got any better, let's have a look and see what's happening, and then realize, oh, there's something wrong with the retina, so there's RP there. And then the vitreous gel, which is the jelly in the eye, can manifest cells. So some people have these cells in the vitreous, and cells are typically seen in people with inflammatory eye disease. And in combination with macular edema, which is swelling of the macula, specialists look at the cells, look at the macular swelling and say, you got inflammatory eye disease. We're going to treat this as inflammation. We're going to look for infection. If there's no infection, we're going to give you steroid, give you immunosuppression to treat it. And it may take years before somebody realizes that, okay, this is probably not inflammatory because nothing is responding and there's additional features like night vision issue, peripheral vision constriction, and then you do an ERG, realize, oh, okay, this is big. So that's the confusing part there as well. There are also people who come with scar on the macula or epiretinal membrane that can occur in RP or macular hole, and that's a surgical problem. So there are surgeons who sees this, okay, we better peel the scar, we better fix the macular hole and do the vitrectomy operation, and then maybe years later realize this patient had other symptoms that they have RP, not the original problem. There's dysdrusen that can occur, so people can see swelling optic nerve or dysdrusen. And swollen optic nerve is medical emergency because we see that in people with brain tumors or high pressure in the brain. So they get worked out for brain tumors, they get MRI scans, lumbar punctures, all sorts of things done to look at why optic nerves are swollen, but not realizing actually there's RP because there's really no other classical signs there except for these. So the diagnosis gets delayed. And there's people with RP with tumors in the eyes, vascular tumors that can be seen in the peripheral retina. That's called vasopolar tumor. And so that can be looked at and thinking, oh, there's a tumor there, we better treat it. And then suddenly realize, oh, there's pigment spicules as well. So maybe this is not just a vascular tumor, it's actually RP. So there's all these ways that RP can manifest, makes the diagnosis difficult clinically, and therefore it's not always diagnosed first up at presentation. Often it's a journey. And so with all this in mind, we now know that it's not just one disease. So that's why I'm saying that maybe retinitis pigmentosa is probably not the best terminology. It's 165 years old, when it was named. There's very few medical conditions now we call by a name that was given 165 years old. So I think it's probably time to move on, not to call it RP. I'm still using the word RP because it's so easy to say. Now, there are other conditions that can simulate retinitis pigmentosa. And there's three categories. When we look at a patient with these pigments, we have to keep in mind that this could be non-genetic, right? This could be related to exposure to environmental factors, so there are drugs that can cause pigment spicules. There are other conditions like retinal detachment that spontaneously recover, can give you these bone spicules. Infection, inflammation can certainly give you that. And so you know, when we see somebody with RP, I can't just assume immediately that this is genetic. You know, we have to make sure that, okay, there's no other clinical features or signs or history that suggest this could be something else, such as drug toxicity, which, you know, obviously very important because we've got to stop the drug first to see to treat it. Then the other two categories are syndrome. So syndrome is very important because they say up to 20% of RP is actually a systemic disease, not just an eye disease. So when I say systemic disease, what I mean is that there are other parts of the body being affected. The most common being hearing. So the first thing when a patient with RP comes in, first thing I look out for is hearing aids, cochlear implants, and any speech impediment, because any changes in the speech or hearing would imply that they might have Usher syndrome. And that's probably the most common form of syndromic RP. Then there's a whole range of other 20, 30 different conditions which are extremely rare, which can manifest in the eye as well as the rest of the body. And they can affect the brain, you can have seizures, they can affect the heart, can affect the lungs, kidneys, liver, digits, bones, whole lot range of things. So these are the things that we need to identify and not just assume we're dealing with an eye condition. The third group of diseases are that can be confused with RP are what we call, well, there's several of those. The carriers, number one, so carriers of X-linked disorders, they don't have typical RP, they have sheen in the retina. And it's more important for their sons because their son are 50-50 chance of getting this condition. Cone rod dystrophy can look like RP. So what cone rod dystrophy is, it's a condition that affects the cone first, which then lead to rod degeneration, so the reverse disorder, disease. A lot of people with Stargardt's disease, which can manifest like a cone rod dystrophy, gets misdiagnosed RP because they can have these bone spicules all around, and oftentimes the clinician look in and say you got poor vision, bone spicules, therefore you got RP. And really it doesn't help them because it diverts the diagnosis away from what they have, which is Stargardt's disease. So I gave a talk about Stargardt's disease a few weeks ago. It's another big group of conditions that can manifest very differently. Some people have localized central lesions, some have very widespread lesions like RP. So we need to separate those two. There are people with what we call vitreal retinopathy. So that affects the vitreous gel and the retina. They can have retinal detachment, splitting the retina, all sorts of strange things going on, structural changes. And then choroidal retinopathy, so like choroideremia, gyroatrophy. So these are much rarer conditions where not just the retina is degenerated, but the choroid layer is degenerated as well. So these are the three groups of conditions that I have to keep in mind, or other clinicians who deal with RP have to keep in mind that they can look like RP, but they're not. Now coming to how we name it. Traditionally, before we knew what the genes were, they were named RP1, RP2, RP3, RP4. And I think it's gone up to RP100 and something. I haven't looked up, but actually there's not that many genes that we know cause RP. It's not 150 genes. There's only about 85 to 90 genes that we know causes RP. And that's because when we assign a number to the RP, we don't necessarily have to know what the gene is. We just assign a number because this looks different. It's in one family where we look for all the known genes and none of them are present. Okay, we'll give a new number. And then years later, we might then find the gene and then assign the gene to that number. And we might find that there's 2 or 3 numbers being assigned to this condition, but they're all caused by the same gene. So then some of the numbers disappear. So if you look at RP5, RP8, they don't exist anymore because we know it's due to something else. RP15, RP16 don't exist anymore. So not all the RP numbers actually exist or have a gene. We know there's 85 to 90 of them. RP1 wasn't the first one to have the gene discovered. In fact, it's RP4 that had the gene discovered back in 1990. So rhodopsin is the first gene discovered to cause RP, so that's RP4. Whereas RP1 is a bit later, but it was the first one to be named. That's why it's called RP1. In fact, the gene for RP1 is RP1, whereas the gene for all the other ones may be different. For RP2, interestingly, you still call RP2. RP11 is the one that we had done most researching. The gene name is PRPF31. So there's a code name, and that's for a gene name. RP12 is CRP1. So there's another name. So it becomes very confusing. So some people call it by RP numbers or the actual gene. I'd rather call it the actual gene because that helps us to understand the disease a bit better. How do we find the gene? This is the biggest challenge we face. So we're not going to call it RP. We better call it something, and the something is the gene name. So for example, what we'd like to call it now is, for example, RPGR-associated retinopathy. So RPGR is the gene name, and we know that's the gene on X chromosome and it causes X-linked RP. So we don't call these people X-linked RP anymore. We call them RPGR-associated retinopathy. It's associated with families with this condition, and we call it retinopathy rather than retinitis pigmentosa because there are situations where this gene doesn't cause retinitis pigmentosa. It can cause a cone dystrophy. So by not committing ourselves to call it RPGR-related RP, we can encompass all the people who have RPGR-related disease. So that could be a carrier, it could be female carrier, somebody with cone dystrophy, cone rod dystrophy, retinitis pigmentosa, whatever you name it. So we know that there's many genes that causes RP, also causes other things, macular dystrophy, cone dystrophy, pattern dystrophy, you name it. So this is where it gets tricky. So that's why we now use the gene name rather than the manifestation, which is RP. In the WARD study, which we established 5-6 years ago, we've been recruiting patients with inherited retinal disease as a whole, as a group. So there is about 500 people in the study now who have inherited retinal disease. Out of those 500, 300 have what I loosely called RP. Now, if you think about the frequency of population with RP, they say it's about 1 in 4,000. So there should be about 620, 630 in WA. So I see about just less than half of all the RP patients in WA. So I'm not including people who are carriers or Stargardt disease or cone rod dystrophy. I'm just focusing on the rod cone dystrophy or RP. Out of these 300, we managed to, in collaboration with Australian IRD Registry, do genetic testing in them. What we found is that we managed to test about 70% of the people. So around 30% of the people we haven't been able to test for various reasons. Out of those 70% of the people, we have managed to solve or find the actual causative gene in about 80%. So that leaves about 20% or 1 in 5 who's still none the wiser what's causing the problem. So if you take that as a whole, say, assuming that these people who are genetically solved are the only one who are solved in the whole state. So out of the 620 people, we're looking at probably less than a quarter of all the patients with RP that have a diagnosis. Right, so the majority of people in this state do not have a diagnosis yet who suffers from this condition. So that's a big challenge. And how do we reach out? Well, at the moment, a lot of people, optometrists, other specialists, have been referring patients to us for genetic workup. That's great. A lot of people don't know who we are, or they haven't seen a specialist, so they haven't had the opportunity to come. Now, once they come to us, there's also a barrier to genetic diagnosis, that is getting the DNA. So there's a huge proportion of people we haven't been able to get DNA from for various reasons. It's not their fault, no one's fault really. Either not understanding the importance of the genetic diagnosis or not having enough time or ability to have DNA collected. So that sort of makes up the 30% who we haven't been able to test. Now, the biggest problem for us is really the 20% who have been tested. So the 70% who we tested and 20% of that who we can't find a gene, because we can't give them an answer despite putting a huge amount of effort into looking for the gene. Just to give an idea, when we send the DNA off to the States to get it tested, it's about $600 to get the test, and that looks at 900 genes that affects eye. So that will encompass all those 80 to 90 genes that causes RP. And then there's hours and hours of work gone into analyzing that data. So overall, the market value, if you like, of genetic testing is actually much more than the $600. It's probably in the order of several thousand Australian dollars, up to 5,000 Australian dollars if you add up all the hours of work that goes into it. And despite that, 1 in 5 we can't give an answer to. Now, this is using a technology called next generation sequencing. There are better technologies around. It's called whole exome or whole genome sequencing, where every single genes is looked at in the human DNA sequence. They are also, so that's a whole exome, and whole genome sequencing when every single nucleotide is looked at in the whole DNA sequence. The more you look, the more complicated it is to analyze. And just because you look at it doesn't mean that you will find it, right? Because you're literally looking for a needle in a haystack to try and find the cause. So current technology is not limited by the inability to look at the sequence, but actually the analysis, and that all boils down to mathematics. So there's a lot of people out there specializing in mathematics, informatics, in working out the statistical processes that's required to find this mutation. And there's grants specifically dedicated by the Australian government to boost bioinformatics capability in Australia so that we can actually crack the DNA code for these patients. So that's the first part of the journey for our patients in the ward study, is to find the cause. Then the next two things are, first of all, we need to find progression rate, and secondly, we need to find a treatment. So I'll talk about progression rate. Now, I already mentioned that some people can manifest the disease early, some can manifest later. Those who manifest early, we assume their progression is fast, but that's not so. The disease is not linear. In fact, for most diseases now, it's not linear, it's exponential. So the progression may be fast at the beginning, but generally it slows down as people get older. And that's why we very rarely find people going completely blind in RP. Now, if disease progression is linear, then everybody will go completely blind, but that's not the case. So out of 300 patients we've seen, only 2 have lost all the visions completely. Right, so that's like another 298 who haven't lost vision altogether. And that's because this progression is non-linear. And because of this non-linearity, it's a problem for us in doing trials. When we want to find out a drug, whether it works or not, we need to know what the natural history is so we can alter it. Now, if you treat somebody very late in disease when the progression is very slow, you might think it works well because you're slowing it down so much. And you treat somebody who's very early in disease, you might think the drug's not working because it's going so fast. But we need to know what's actual natural history before we know whether the drug's working. So we got to understand for each gene, each mutation, what is the actual rate. So our patients are monitored 6 monthly or yearly, sometimes longer, depending on the progression rate, for us to get an idea what the actual rate of progression is before one day, hopefully, there's a treatment for them. And that's done by various methods. One is through imaging. So we take a lot of detailed photographs of the eye, and that will show us all the layers of the retina, the thickness of the retina layers that are still working, and the extent of the central retina that are still working. So we work with computer scientists in Perth and also in Brisbane, looking at how we can mark these images so we don't have to spend hours and hours doing this marking ourselves. So machine learning will do that for us. And then that will allow us to analyze hundreds or literally thousands of images quickly. The other way to monitor is by looking at function. Unfortunately, function it's very difficult to measure. So you could ask somebody, how's your vision? Say it's good or bad or progressing, fluctuating. It doesn't tell us how it's progressing. You could give a score out of 10, still not very accurate. We could even measure every single point in the retina, how sensitive to light it is. It's called visual field test. That's still not accurate either, because from day to day, you can get a different result. We can measure the individual location with electrophysiology, shining light into the eye, but that's not practical because each test takes about 3 hours. I'm sure many of you have been through that. You never want to go through it again. But the FDA wants to know function because they can't approve a drug until you can show them that the function is preserved or improved. So there lies the big problem for us, is that we can't actually measure function accurately in RP. We can measure the structure or the layers of retina accurate, but the FDA will say, well, what's the point of preserving this layer? You can tell me this is 300 microns, but what does it mean for the patients? Right? The patient needs to be convinced that they're seeing better or stabilizing. And we've got to have some way of measuring that the retina is functioning just as good as when you start the treatment, or not much worse off than the natural history. So that's an area of intense research now all around the world, trying to work out what is the best way to measure function. There are several trials around, you've heard of gene therapy trials, where they failed because they failed to demonstrate function, stability. It's very unfortunate because, you think about all the time, effort gone into producing the gene therapy, getting it tested, validated, put into the patient's eye, running through years of trials, and at the end of that, well, we can't approve it because the function doesn't show any, functional test doesn't show any benefit. Now, it may be that it does show some benefit, it's just that we don't have the capability to technical ability to find it yet. Right, so we're at risk of losing effective treatment because we don't know how to measure the retinal function. And so, it's almost a shame because you put so much effort into all these other things, and yet the most basic foundation or measurements is not understood. And it's not really well appreciated by researchers all around the world that it's not very exciting measuring function. You ask any kind of researcher, we'll rather look at DNA molecules and sequences, all this fancy stuff. But when it comes down to the crunch to a patient benefit, we don't understand the most basic step. We can't actually move on. So this is about progression analysis and functional analysis. Now, finally, the last bit of the Ward study is about treatment. So there are two broad treatments that we're looking at. One is gene-specific treatment, and the other one is generic treatment. So we know that in RP or rod cone dystrophy, which I should now call it group of condition, the rod cell dies, followed by cone cell death. These cells are dying because of a couple of things. Oxidative damage, so the gene mutation can cause the buildup of products in the cells, which then kills the cells. So there are trials looking at antioxidants that will treat potentially all forms of retinal degeneration. If there's a buildup of waste product that the cells can't get rid of, there are drugs that helps with that process. So that's a sort of more neuroprotection generic aspect of treatment. The gene-specific treatment is about looking at ways to replace the defective gene. So remember when I mentioned about recessive condition where there's 2 mutations in the gene? Well, it's possible that if these 2 mutations knocks out the entire gene, you can replace that with gene therapy. So that's called gene replacement therapy. So it's a technique where you put a small segment of DNA that carries a sequence of that gene into a virus, which is then injected into the retina. And then this virus then infects the cells, deliver the sequence so that the cell can use it as though it's their own DNA sequence. There are a couple of problems with this technique. One is that it requires an operation, so surgery to inject the vector into the retina. So there are new techniques now using gene therapy without having to inject under the retina. So you can just inject into the vitreous cavity, the virus then travels through the vitreous into the retina. So that's moving along. The second problem is the uniformity of these cells being infected. So there's some cells that are infected more than other cells, so you get uneven dosage. And furthermore, you can't control how many of copies of this gene are going into each cells. Right? So each cell technically only needs 2 copies. When you infect it with a virus, you can give it 1,000,000 copies or 1 copy. Right? So every cell is a slightly different number, and that dosage of the gene is difficult to regulate and may actually cause a problem later down the track. The other way to fix the genetic mutation is to look at the actual mutation. So there are mutations in the gene that affects the way it's processed. So for example, some of the genes are processed in such a way that certain segments are missing, or exon skipping, or certain sequences of DNA are incorporated unnecessarily. And so there are molecules that can bind to the RNA molecules or the gene sequence to alter that process. So the whole group of drugs are called, this drug is called antisense drug, or RNA inhibition drugs. And these are more specific for the actual mutation than the gene. So the difficulty there is actually you're going to have to produce different types of drugs for different people, even if they have the same gene that's affected, because their mutations are different. So you're really virtually developing the drug for the family, and that's it. Really not for many other people in the world. Out of all the genes and the mutations we come across, we've been fortunate enough to work with Professor Fred Chen at Murdoch University, and then partnering up with PYC Therapeutics in developing what we called an antisense drug for RP11. So in RP11, the gene is called PIP31, people get retinitis pigmentosa due to a mutation in that gene. It's a dominant mutation. And therefore, what happens is that one gene is knocked out, but the other gene still functions, but not sufficient enough for the eye to function normally. So they develop retinitis pigmentosa. So in this condition, what we like to do to treat it is to boost the level of the normal copy with the drug so that it can overcome the deficiency on the other copy. So rather than, if you say 200% is the normal amount, so you got 100% from the mum and 100% from the dad. In RP11, they only got 100%, so half the amount of normal. If we can boost that by 50% to 150%, then we think that's sufficient enough to prevent progression of disease. So currently, this treatment's been developed in PYC, and there's plans for clinical trials in the next couple of years to test the drug in human. There are a few other genes that we develop gene therapy for, where we package the sequence of the gene into a virus, and now we're testing them in cells of patients that we collected from their skin. And so all this work really is not possible without the funding we received from families, donors at Lions Eye Institute, as well as grants that we received from NHMRC, Telethon, other institutions, and also the support of Lions Eye Institute infrastructures. I think I shall stop there and answer any questions anyone has.
Thank you very much.
That's right. I'll operate the, you do that, and I'll operate the muting thing so that we don't end up with lots of feedback. I don't want that doing. If you stay up there, and then I'll just do this bit from here. So we're going to go online first, maybe. Shall we give that a go?
All right.
Let's have a look. So if you're at home, you can unmute yourself now and ask a question first. Give this a go, see how it works.
If you're in the audience, we can put up your hands. I'll run to you with a microphone.
Dr. Chen, thank you for the presentation, really helpful. I just recently read about the supplements that you can take called NAC, acetylcysteine. Have you heard of that? Is that useful?
So the clinical trials in NAC is still ongoing. We don't have any information on how effective and what dose you should be taking for the effect. The theory comes from working in animals where mouse with Retinitis Pigmentosa demonstrated preservation of the cells and the function in their retina when they were given this drug. Right. Now, we don't know if that drug then applies to just the animal model, just that gene, or other genes in humans that's affected by it, and at what stage of degeneration will be beneficial, we don't know. But in principle, animal model, it should work in human with it. We just don't have the data yet. So the trial's ongoing in the US. You can access an N-acetylcysteine online, so it is already available. It's actually used for treatment of liver toxicity, people with overdose, and to prevent kidney damage in people receiving radio contrast dyes for angiogram. It also helps with thinning out the mucus in the lungs in people with chronic lung disease, like bronchitis and things like that. There are mild side effects from the use of the medication at high doses. We know that it can cause gastric upset. Some people might even get headaches. Liver toxicity potentially, even though it was used to prevent liver toxicity. So it's something that people can explore if they want to. There's no, I wouldn't, I say prescribe it for everyone, but it's out there.
Thank you.
We've invited people online to let us know when they have a question. Do we have any other questions in the room? Yep. Oh, one down the back. Yes.
I think we've got someone online, Maria.
As well. Yep.
All right, so the person online, if you'd like to ask now, you should be heard in here.
Okay. Hi, thank you. Thank you for the presentation, Dr. Chen. My name is Arif. Now, Doctor, I wanted to find out about, so I have been looking at ways to improve my peripheral vision. And I have come across a US website, which is the International Academy of Low Vision Specialists. And they specialize in these side vision awareness glasses. Now, I've not come across any optometrists or anyone here in Australia that can make these glasses. That's what my question was. So I've got in touch with them. I might have to, because this is mainly for to keep me driving, right? So my central vision is good, but I have difficulty with my peripheral vision. So I want to, yeah. So my question is there any one in Australia that specializes in these types of glasses?
I'm not aware, actually. It's interesting. I can have a look at it.
Yeah, so the website, I mean, just for your reference, it's called the International Academy of Low Vision Specialists. It's IALVS.com. So there are specialists in the United States that specialize in these types of glasses. So yeah, that's what my question was. Yeah.
If I find out, I guess I can let Maria know and
thank you.
Pass it back on to you. Thank you.
Thank you.
Thanks, Dr. Chen, for a great talk. Someone had gave me a couple of papers the other day about low-level laser therapy for RP. Have you come across that? Seems.
I think it's another fancy name for that would be photobiomodulation.
Yeah.
Yeah. So there's several trials looking at photobiomodulation. It's sort of started with the idea that this red light can stimulate energy production in cells in the mitochondria. So mitochondria is sort of the powerhouse in each cell. And they tried it in diabetes in a big clinical trial, which unfortunately showed no benefit. So people were given it in the hope that they can avoid progression and treatment for the macular edema in diabetes. People are using it for age-related macular degeneration as well. And so until we have clinical trial data, I'm not sure if that's beneficial yet.
Yeah, because there seems to be only one paper with 14 patients, but probably not enough to. draw a conclusion, is
Well,
it? Yeah.
I guess, when we look at a therapy, we run them through 3 series of trials. The very first trial could be 14 patients or 10, is to look at safety. And so these trials are designed specifically to make sure that these therapies don't kill cells and don't blind people, and there are no harmful side effects that people are not aware of. Obviously, rare side effects cannot be picked up by just 14 people. And then the second phase of the trials, phase 2, is to look at efficacy or benefit from the treatment. So then you have to start to give people placebos, because otherwise you wouldn't know whether it's any better than natural history. And then in that kind of trial, generally they have 50 patients, maybe half gets this, half gets that, or 60 or 100 patients. A third gets nothing, a third gets a low dose, and a third gets high dose. And they get compared across 2 years, or however it takes to get a difference. And then look at the result at the end of that. Now, a 2-year trial actually takes about 5 years to run, because it may take 2 years just to recruit those people, and then 2 years for the last person to finish, and another year to get the analysis done. So after 5 years of first patient going in, you might then get an idea whether it's working or not. Then you do a phase 3 trial.
Yeah.
Phase 3 is what FDA requires, even bigger number, to make sure it works. Otherwise, with the investment you go into developing it, and then to pay for the drug for all the population out there, they need to make sure it actually works. So phase 2 trial is good for giving a hint where something works, but phase 3 is the actual one that allows you to use it, or for us to prescribe it. So it's a start.
Yeah. Okay. Thanks a lot.
That's right.
Do we have any more questions for anybody online?
There's a couple coming through.
All right. Do you want to nominate one for us, please, Magda?
Tracy.
Tracy.
Go.
Yep, we can hear you.
Just talk. Hi, there was an article on Channel 9 News probably about 6 months ago in Perth in regards to a bionic eye for RP patients. Bionic eye.
Okay.
Do you know anything about that?
I'm not aware of the actual article, but I can talk about bionic eye in general.
Yes.
The very first bionic eye was Argus 2. I was involved in that trial 2008 or 9 in the UK. It was indicated for people with no perception light. Right? People can't see any light at all, so they were given the opportunity to have this bionic eye put in. It was a struggle to find those people. As I mentioned, out of 300, we could only 2 people will be eligible. So we found 6 people in London to put the implants in. The kind of vision that they got after bionic eye surgery, which took about 3 hours, was flashes of light. So they were able to see nothing before to seeing flashes. These flashes were enough for them to decipher whether an image in front of them is a letter E or letter I, or horizontal line or vertical line. They can probably see some of these patterns enough to recognize the letter, but for a lot of these patients, practically they haven't seen any form or letters for 20 years. So for them, it's kind of a new concept for them to see a letter. They couldn't use it to cross the road because they need a lot more vision than just flashes. Now the bionic eye has advanced since then. We're getting better than just flashes of light. There are bionic eye that has thousands and thousands of electrodes put in, so it's put on the macula, or it's put behind the retina to encompass the entire visual field, so not just the central part. So the only bionic eye in Australia that's been developed is in Melbourne. So this is a suprachoroidal implant. So currently only a few patients had it put in. They're still developing it, so they haven't given it up. Unlike Argus 2, that's all got shut down because there weren't enough people it can be useful, because it was only useful for people with hardly any vision.
Okay.
So it's still a work in progress.
All right. Thank you. Thanks.
All right, we got one more in the theaterette here, Maria. We'll just swap around and.
Pop your hand up if you want to. No.
No? Okay. What's the next one online, please, Magda? Helen. Please unmute yourself, Helen. Or can you unmute Helen from there?
Okay, hi. You mentioned earlier that when you meet a patient for the very first time, you look to see whether they have hearing aids. Why is that? Because I know I have retinitis pigmentosa and that it affects the macular part of the eye. I also have mitochondrial disease. So I'm just curious that you brought that up because I do wear hearing aids as well and how it's connected.
Okay. So there's a condition called Usher syndrome. There's a handful of genes that can cause Usher syndrome, type 1, type 2, type 3, and even type 4. And in these people, they have both retinal degeneration and sensory neurohearing loss because the gene that's affected is important in the development of the inner ear. Right? So they were born without hearing or with impaired hearing because the cells, the cilia in these hair cells are not developed properly. And then maybe 10 years later, they may present to an eye specialist with impaired vision as well, because it takes that long for the constriction to occur, so that the eye manifestation tend to occur much later. So they were diagnosed with congenital hearing loss, and then maybe 10 years, 15 years later, present to an eye specialist with retinitis pigmentosa, and then suddenly the penny drops at, oh, okay, you have Usher syndrome. Nowadays, it's slightly different because when the child presents with congenital hearing loss, they're starting to do genetic testing. And they actually find in some of these kids that, oh, they have an Usher syndrome, but their vision is perfectly fine. And so we have the opportunity now to actually start monitoring their eyes before they even manifest a symptom. And if there's a treatment for it, then that's great. We can treat them before they even lose any vision. Now, with mitochondrial disease, you're right, it can also affect hearing, and that's to do with the energy demands in the inner ear cells. It's probably greater than other parts of the body. But mitochondrial disease is not just limited to the ear or the eye. It can affect other parts of the body, the brain, the heart.
Certainly does, yeah.
Yeah. And hearing loss is one of them. In fact, there's several other diseases other than Usher syndrome that affects the eye and hearing, and we certainly come across quite a few of those.
Okay, thank you. Thank you.
Excellent. Do we have any more questions online or any more questions in the theatre out here? No, I think that's all.
Gone. Auction over, I think.
Did you want to say anything in closing?
There's hands raised up there.
Oh, yeah.
Jason Smith and
Sorry, who had their head up?
oh no, in here, on the screen here.
On the screen.
Yeah.
Oh, yes. We had, I think, Tracy asked a question and
Jason Smith.
Jason, not sure.
If Jason wants to unmute himself.
We can help unmute him. Jason.
Sorry, I forgot to put my hand down.
Oh, okay, cool.
You need to unmute Jason. Oh, okay, excellent. No, I think we're probably good to...
Jane.
Oh, Jane. Jane's going to unmute you. Right.
That's right. Yeah, we'll go to that one while Magda or Maria could
Still
unmute
muted.
Jane's for us.
I've just unmuted myself, Ryan, I think.
Oh, there you go. We got Jane, and then we'll go to the person in the audience here. So go for it, Jane.
Thank you. Thank you, Dr. Chen. That was a really interesting talk about all the challenges that you face as well. I'm interested to know what inspired you to work in this field.
Okay, good question. when I returned from London to Perth, this is not an area that I would imagine I'll be doing. It sort of started 5-6 years ago when I came across patients who were referred for treatment trials in age-related macular degeneration. And some of these patients, in fact, had Stargardt's disease. And then I started to realize, actually, there's not much known about Stargardt's here. In fact, people were misdiagnosed with AMD. And then we were fortunate enough to have funding from a family who had a member of the family with retinitis pigmentosa. In fact, this patient was diagnosed with autoimmune retinopathy for several years. And when I became involved in the care of this family member, it became apparent that she actually didn't have autoimmune retinopathy. And it took a while to work that out because we had to go through all the steps of genetic analysis and ruling out the variations and then doing laboratory experiment to actually confirm the mutation is actually a mutation. So that took a couple of years to work out. And then because of the funding being available, we were then able to start looking at other patients with inherited retinal diseases, not just the ones with Stargardt or the one with this autoimmune retinopathy, which turns out not to be autoimmune retinopathy. And so for the last 5-6 years, we've been wanting to know more what the genetic spectrum of these conditions are, because there seems to be no one else doing it in Australia, in WA, and what the natural progression is. None of these patients have ever been monitored. And then using our skills in the lab to try and develop treatment for them, because there wasn't any around. There's only one gene therapy available, that's Luxturna, but that's only for a very, very small fraction of everyone, all the people with the IRDs. So there's a huge need, and we had the financial support and the capability, so that's why we're doing it now. And also, most importantly, when we did a study in collaboration with Visibility, we looked at the course of blindness over the last 20 years, going through all the blind registration. It turned out that inherited retinal disease is the most common cause of blindness in WA in the working age group. And when we look at across all age groups, it was the second most common cause of blindness after age-related macular degeneration.
Thank you.
And I think we had one more question in the audience for you.
I just wanted to ask if you could comment on cataracts related to RP, and would you treat them in the same way as normal?
I think that microphone's about to...
Sorry, what's the question again?
If you could comment on cataracts.
Okay, right, okay.
And do you treat them in the same way?
Okay, so there's a couple of issues with cataracts in people with RP. The first thing is that there are people with RP who manifest cataract very early on, almost like congenital cataract. So that's dealt with very differently because you got to get rid of the cataract, otherwise they won't be able to see and develop visually. But then most of the cataract we come across in RP are incidental, but they're certainly not causing any symptoms. They're usually on the back of the lens called posterior subcapsular cataract. The kind of symptoms that can cause is glare or halos. Now, glare symptoms is also quite common in somebody with RP without cataract. So it's actually difficult to differentiate between the two, whether this is a cataract-related symptom or RP-related symptoms. Later on in life, people then can develop the age-related form, nuclear cataract, which reduce their visual acuity. So it's not just causing glare, halos, but also the acuity drops, so they can no longer see the top line of the chart or the bottom line of the chart. So, that kind of cataract is treatable with current technology. Cataract surgery is just the same. The biggest catch, though, is that people with RP tend to have weaker ligaments around the lens, so there's actually greater complication rate. And something that it's not obvious to most surgeons until they do one. They realize, oh, this lens is very unstable. And we often see that in my cohort anyway, people who've had cataract surgery, the RP patients, their lens are very unstable because the ligaments are already damaged, probably before the surgery and probably during the surgery as well. And so it's probably a good idea to avoid it until you really have to have it done. And then if you do need to have it done, be very careful with it because there's high complication rate with it.
Did I just check that somebody else had something to ask online?
Oh, spot on, Ryan. My goodness, your ESP is extraordinary. We do.
It's about the only part of me that works well. Go for it, ask away.
I just wanted to get an idea of how many children with RP that you're currently seeing. I'm trying to get an idea of how common childhood RP is, because you see my son, you're great, but I'm keen to know how many other people here have got children with RP.
Yeah, so there's two components to that question. One is how many RPs actually present in childhood, because technically RP starts at birth, but we just don't see them until this becomes symptomatic. So RP typically don't present in childhood. So most of the people with RP present after childhood, even though the disease starts at birth, just don't have any symptoms, or symptoms are mild, they don't need to come and see us. Those people who present at childhood, they have very early onset RP, and there's probably about 20 to 30, I'd say, in WA that I'm aware of, based on what I've seen in the registry and in my clinic. But we do know that the registry is not capturing all the RP. So I'm pretty sure they don't, and it's probably at best half. So there's probably a lot more out there, either not diagnosed, misdiagnosed, or seen by other private clinicians who hasn't referred them. Oh, there's a question up there.
Yeah, was there a second part to that question as well?
No.
No? All right, what's the next question?
There's a question over there on the side, on the right-hand side. Oh, that's fine. We've got
Sure. Thank you.
10 minutes.
Just sticking to the same vein, at what age, if someone's not showing any symptoms, what age should they start getting tested?
Oh, very good question. There's no straightforward answer, unfortunately, because each gene is different, and even within the family, it can manifest at different age. And so we could be mistakenly diagnose somebody without any problem when they can manifest later on in life. Now you could look at in a dominant family, you could look at what's kind of average age people present and use that as a rough guide, but that can be quite misleading. In a recessive family, it's probably, so it means that you've got one child with a recessive condition and another child, as they get older, what age to test it, you could use that as a guide. When they present at 5, in the first child, you probably want to monitor the other one earlier than 5. If they present at 20, you probably monitor that just before 20. But the best way, I guess, is to diagnose it genetically, so you know for sure whether they are going to get it or not. But that requires us knowing the gene, which we can't find 1 out of 5 times. And then if we do find the 4 out of 5 gene times that what the gene is, there is a chance that some genes will manifest with the disease as well. PRPF31 is one of those. We know that 10% of people carrying that mutation should have RP, but they don't have anything wrong with their eye. Right. So there's no straightforward answer, unfortunately. I think it's just worth monitoring as the usual schedule, and just be vigilant. So whoever's monitoring knows what they're looking for specifically. Excellent.
So a couple of more questions, last call. Anyone online?
Angela's gone. That's all right.
You can ask as many questions as you like.
Can you comment on that trial? I don't know if you know about it. They're starting a clinical trial in Adelaide with those synthetic pigment absorbing molecules. Do you know anything about that?
No, tell me more.
I just got a thing through Retina Australia that they're looking for people to do this clinical trial, and they seem to be synthetic light-absorbing pigments that attach to nerve cells and transmit signals to the brain.
Oh, okay. You might be talking about optogenetics. Is that the one? Because there are pigments, or different kind of pigments in the eye. The commonest pigment we know of is melanin. I mean, you wouldn't want to just put melanin in unless you have albinism. Albinism is a condition where there's no melanin in the eye. The other pigment is called visual pigments, and they're the pigments that responds to photons. So in the rods and cones, they are visual pigments. But in RP, you lose that because the cell dies. So it's possible to put these visual pigments, or pigment-like molecules, in the ganglion cell. That's another layer up where it's not degenerated. So that these ganglion cells can become a bit like photoreceptors. And that's done by gene therapy. So the gene vector carries that the vector carries this gene into the ganglion cell, which then makes this visual pigment. And so then the retina can start to respond to light, or send the signal to the brain once the light hits that pigment. So I wasn't aware Adelaide is doing that, but I know there are other places in the world doing optogenetic trials.
So they're obviously going to start a clinical trial there.
Right.
Yeah. And they were asking for people with severe RP.
Yeah, so severe RP is the key word, because a bit like the bionic eye, you probably wouldn't get that much benefit if you already got vision in the sensor. So they're probably looking for people who can not see any light at all, or could just see bare light perception, simply because we don't know what vision they're going to get just from this optogenetic treatment. Now, they could just get flashes like the bionic eye, or they could get a pattern and that's it. So if you can read the chart, your vision is probably way too good for this kind of treatment.
I did actually send that email on to Maria, Magda and Lynn yesterday, so they could possibly share it with you.
Oh, great, thank you.
As well.
Yeah, okay.
Yeah. But I do recall it, yes, it was through Retina Australia.
Yeah.
Okay.
Any more questions? Anyone online wish to ask one of the last questions for the day?
There's another one coming through now, Ryan.
Yep, I've unmuted you on here. If you could unmute yourself at home, please, for us. Or if you have to, you could type it into the text field and we could get Maria or Magda to read it out.
So, Ryan, Lauren is asking about Luxturna and when that might be administered in Western Australia.
Thank you, Lauren.
This is a good question. So first of all, we got to find patients with this condition. I am only aware of 2. And second of all, we need to have the infrastructure. And we've been working with the Children's Hospital and Department of Health, looking at funding models for this treatment. Currently, it's still not available, so it's a work in progress. The company that sells Luxturna need to train sites personnel and surgeons to do this treatment. So in fact, they have to invest a lot of time into making this happen. They've chosen or decided a couple of years ago that in Australia, there are only going to be 2 places in Australia to do it. So they've chosen Sydney and Melbourne. And so for us to be a site, we have to convince Novartis, as a company that sells the drug, that it is worth their time and money to set one up here for just 1 or 2 patients. Now that might not seem feasible, but I'm looking at longer term. Luxturna is not going to be the only gene therapy. There will be other gene therapies, maybe not sold by Novartis, maybe other companies may be selling them. And so currently it's a struggle, simply because there's only so few people with the condition, and the company can't set up a 3rd site. And that applies to people in Adelaide or Brisbane. They will have to travel to Sydney or Melbourne to get Luxturna as well, as it stands, until something changes.
Any other questions? Last chance for questions. All right, so if everyone at home would like to turn their cameras on if they wish, because you can do a wave. And I'll ask everyone in here to give Professor Chen an applause and say thank you for his presentation today. Yes, okay. Well, thank you very much, Professor Chen, for joining us today. Really appreciate you giving up your Saturday morning to be here. And we look forward to maybe inviting you back again.
It's a pleasure. Thank you, Ryan.
Thank you.